So welcome everybody to the webinar, Maximizing Your Budget Using a Novel Hemodynamic Monitor. I'm going to just wait another minute for still some of our late arrivals to come on board, and we'll get started shortly. If you're just joining us, we're just going to wait another minute as people are signing on, so just be patient. We'll get started in another minute or so. If you're just joining us, we're just going to wait another minute as people are signing on. All right, well, let's go ahead and get started. Welcome, everyone. My name is Mark Zemmel. I'm the CEO and co-founder of Raytia Medical, and we're pleased to host you today. We have folks from across the United States and around the world joining us, so thank you for taking time out of your busy schedules to discuss maximizing your budget using a novel hemodynamic monitor. I'm really pleased to welcome our distinguished panel of nurses from actually a wide variety of roles in the hospital. And I'm very excited to hear their different perspectives and have them share with you their expertise on managing patients during really unprecedented times for us. There's going to be a 30-minute presentation and panel discussion, and then another 30 minutes where we'll do questions and answers. So I really encourage everybody on the line to send in their questions because this is why we're here, to help you, address the issues that you're facing today. And so with that, I'm going to turn it over to Morris Nguyen, who will introduce our speakers.
Thank you, Mark. Thank you. Welcome everyone. I am very pleased to be moderating today's discussion. My name is Morris Nguyen. I am the founder and managing director for Predicate Healthcare Performance Group, where we identify the mechanisms that drive evidence-based change, which is quite appropriate given today's discussion. So before I kick off today's agenda, I'd like to just welcome and ask each of our esteemed panelists to please introduce themselves. I'll start off with Kathy Johnson. Kathy.
Good morning, everyone. Thank you very much for joining us, and thank you, Morris, for the word esteemed. I have been in critical care for over 30 years and really have been at many different levels, from bedside staff nurse, ICU manager, director of critical care, to assistant director of critical care telehealth, EICU at Presence Health in Chicagoland area. So I have worked with caring for the most vulnerable patient populations, the adult patient populations, for most of my adult life, and worked with the sepsis, surviving sepsis campaign since its inception in 2005, and worked with the health system to bringing protocols, higher standard of quality care to those patient populations across our health system. So worked with many different individuals to keep that patient up front and focus as I looked at what was needed to care for our patients and our staff in my healthcare career.
Hi, my name is Janice Noon. I have been a registered nurse since 1972, and have had a long history of working at the bedside with critically ill patients. Actually, since 1973, I've done critical care almost entirely. About 20 years at the bedside as a direct caregiver, also working at the bedside as clinical nurse specialist. And I've been fortunate enough to work on projects that were similar to this in standardizing practice protocols and working with acute patients to facilitate better outcomes. I've also been in education, and all of these roles have really led to probably what I'm most proud of, and that is being an ICU manager. And as an ICU manager, all of the things we're talking about today are very important to me. And of course, I'm always concerned with cost of care and throughput of patients, and that's in my manager hat. But my heart really lives with having better outcomes for patients and also understanding new and innovative treatments that can push us to the next level. So thank you for having me.
And finally, the least chronologically experienced of the nurses here today, coming up to 7 years now as a RN exclusively in critical care. I have done a lot of work in some bigger hospital institutions at the bedside, and I've also done travel nursing for a few years in different size and different types of hospitals all over the country in the United States here. So yeah, I'm just really excited to be a part of this and continue to spread the critical care knowledge to some of you listeners.
Well, thank you all for participating in today's panel discussion. I won't do the math on how many years of experience we have here in the panel, but I can tell you it's a lot. So thank you all for bringing your experience and your perspective to today's discussion. So talking about today's discussion, what are we going to talk about? Well, we are really going to answer a fundamental question about how should medical technology companies deliver value beyond clinical outcomes. It's always been important that technologies demonstrate value beyond just clinical efficacy, but especially in light of today's turmoil with everything that's been created by COVID-19, it is critically important that we have this discussion. The pandemic raises questions about the ability of hospitals to remain financially solvent amid unprecedented changes. So what strategies must hospitals make? These changes, while needed to respond to the COVID-19 pandemic, threaten the financial viability of hospitals, especially those who are heavily reliant on revenue from elective services. So what are the things that they should consider? And now with patient volumes sharply rising from rescheduling of elective surgeries, on top of the demand for critical care services from existing COVID-19 patients and new ones, what is the right strategy? Can simply adding the right advanced hemodynamic monitor provide the clinical outcomes and cost savings advantages that are necessary to move ahead? And we'll find out today from our panelists why the Argos cardiac output monitor from Radian Medical makes the most sense amid the current strategic imperatives. So with that, I'd like to turn it over to Kathy to kind of lay the groundwork for us. Excuse me, apologize. We have before I do it, Kathy, we have a poll that was sent out and posted on social media, and thank you for those that responded. The poll asked, what has your hospital done in response to the financial burden created by COVID-19? And given the answers of fast-tracking innovative technology, increasing ICU surgical bed capacity, decreasing equipment supply budgets, and all of the above, you can see here the responses are pretty evenly distributed across the board, with most saying that they have to decrease equipment and supply budgets. This comes in contrast to a time when we should be expanding budgets to accommodate more innovative technology to address some of the problems that COVID-19 is presenting. However, there's been obviously some offsets to budgets and to different resources as a result of all the canceled elective surgeries. So in today's discussion, we're going to really explore how technology can help augment some of these responses. So Kathy, over to you to talk about the financial burden.
Thank you, Morris. So really looking at the financial burden due to COVID-19, we all know it was massive, it was immediate, it was disruptive, and it is ongoing. We have not seen anything in our lifetime in our healthcare careers, no matter how long all of us, as Morris said, put those years of service to patients together. We've just not seen it. So it's been over 100 years since we've had this type of pandemic, and it hit every area of healthcare and demanded almost overnight change. So really managing competing complicated budgets is difficult in the best of times. COVID-19 added so many competing priorities. So my belief, my understanding, and everyone that I've worked with in my career, administration, management, is very focused on taking care of that patient, keeping that patient at the center, and then making fiscally responsible decisions that are going to be benefit to the patient, improve quality of care, and take care of that frontline bedside staff. Really across the country, the hospitals have made tremendous changes. ICU beds had to be increased dramatically. Whole units were reimagined. Every trained and specialty care clinician needed to be brought together and looked at as a model of care. How do we care for this overwhelming influx of patients, maintaining the quality of care while we're learning to take care of those patients? Surgeries, anything non-essential, which we know are many of the revenue generating up to 30% of hospitals' bottom line with these, procedures that are necessary and needed for patients, were canceled. There's also been increased spending on critical care devices such as ventilators, increased costs on PPE. We also know that in some areas of the country, some hospitals and states have been taken advantage of. It was low volume with ventilators and PPE and very high demand. So there had been some price gouging. Again, looking at the budgetary didn't help to have price gouging going on while all of us and all of you were trying to care for these critically ill patients. So there were transformational hospital changes immediately. The American Hospital Association really looked at 4 areas through March through June of how this is affecting American healthcare. They were the costs associated with PEE, the loss of revenue to the hospital, the net financial impact of COVID-19, and then the cost of some additional support given to healthcare workers that some hospitals provided. So the Kaiser Foundation looked at the COVID-19 patients and determined the cost of care to be between $20,000 and $88,000, depending on the need for ventilation. Fair Health looked at obviously the same population of patients, and their estimate was $38,000. So again, a very high cost of care delivery because of the critical nature of that patient population. So COVID-19 pandemic is affecting every area of our society. We can debate whether we're still in the first wave, getting ready for the second wave. We do know that some states that were in their reopening phases have actually pulled back. Texas is one of those states that just pulled back because of an increase in cases, which they believed was going to start to make a negative impact on their hospitalizations and their healthcare providers. So if we really look at how rapidly we had to change, the very first case of COVID-19 was diagnosed mid-January 2020 in Washington State. As of this week in the United States, we have 3,200,000 cases, have diagnosed cases. And there's over 121,000 deaths. The deaths of our friends, family, of families being disrupted, and severe loss for those affected by a COVID-19 death. And unfortunately, those deaths and cases are going to continue to climb. So what is our challenge? Looking at AHA looked at, projecting $202.6 billion in losses, and that equates to $57 billion per month in hospital losses. Everyone on this webinar has their own hospital, depending on whether your hospital system, size, and your services. We all know that's millions of dollars potentially to a bottom line. So, you know, the impact, you know, how do we always want to improve the quality of care of COVID-19 patients? If we've got fixed costs that we can't change, what are some of those other things that we can change? And through innovative technology, can we decrease the length of stay? Hemodynamic monitoring, giving direct information immediately to your clinicians, can we change the length of stay and decrease comorbidities? The American Association of Critical Care Nurses obviously is clearly following COVID-19 and has a lot of information on the website for our members. And some of the comorbidities and symptoms seen with COVID-19 cardiac-wise: congestive heart failure, acute cardiac injury, secondary MI due to respiratory failure, and myocarditis. So, you know, as a very broad overview, that's just a few of the things from administratively thinking about new technology moving forward, looking at current budget and strategic budget. Next, we know with COVID-19 patients that fluid management is critical. Fluid management is critical in many patients, and certainly in critical care patients. And there's really that fluid optimization curve. Either side of the curve, you can have organ failure. So the goal is fluid optimization, determining whether or not what's preload, afterload do you need to care for that patient. So it's all about perfusion, 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 perfusion. 54% of COVID-19 patients have respiratory failure. We all know with ARDS is being shown, and everybody is looking at studies, how it's being treated, et cetera, et cetera. So with fluid optimization, the Argos Redia monitor, immediate cardiac output. You utilize the monitor, and within 20, 30 seconds, you have information with very little information put in for the patient. So decreasing comorbidities is essential. This is the Argos cardiac output monitor, and again, administratively, one of the things that you're looking at is there's no disposables with this. This is really, you can save your bedside RN, your bedside staff, clinical staff, a lot of time setting up this monitor, because if you have a patient arterial line, which obviously very critical patients do, you connect the arterial line to the vital sign monitor, and with the correct cable, and then that monitor is going directly to the Argos cardiac output monitor. You put in very little information. It takes you about a minute: height, weight, gender, and age. And then you are immediately getting information that you need to rapidly care for your patient. So you're not breaking any lines, you're not bringing in expensive disposables, you're able to connect your monitor via the arterial line and utilize the Argos monitor for information.
Well, thank you, Kathy. That was great foundational information about obviously the enormous impact that COVID-19 has on the financial infrastructure of hospitals and health systems, and certainly the thought about managing fluids for these very fluid-sensitive COVID-19 patients makes sense, and there's an ample amount of evidence that supports the use of cardiac output monitoring to guide a fluid resuscitation strategy. And given all of those criteria of ease of use, consistent accuracy, and the lowest total cost of ownership, it seems like the Argos floats to the top. Thinking about how this kind of fits in all in the overall operational strategy for a hospital, I'd like to share a quality improvement study that was performed a couple of years ago in a 300-bed Midwestern hospital. And this is, although not COVID-19, it shares some of the similar patient characteristics as a COVID-19 cohort, this is particularly in the severe sepsis and septic shock patient population. Originally, this study enrolled 48 patients, but at the time of final analysis, 23 were included in the final analysis. Again, it's DRGs 870 and 871, which is the most severe DRGs for sepsis. So these are the sickest of the sick patients with sepsis. And it's a retrospective cohort chart review to determine the differences between the baseline severity match cohort with the study population. Overall goal of this is to demonstrate that by simply reducing care variation and through a protocolized fluid or volume resuscitation strategy guided by a cardiac output monitor can indeed not only improve outcomes, but by extension, reduce overall costs as well for the care of that particular sepsis patient. One of the things you'll notice first is that there was a reduction in the ICU average length of stay. One of the biggest cost drivers for an ICU is, of course, every ICU length of stay every day extends the cost of that. Next to that is the new onset mechanical ventilation. By simply managing the volume resuscitation strategies for these patients using a cardiac output monitor, the study was able to demonstrate a reduction in new onset mechanical ventilation, as well as a significant reduction in new onset dialysis. The logic makes sense here, at least the clinical logic does, that if the patients are euvolemic, there is not a need to keep them on extended times on mechanical ventilation or have them go through dialysis because their fluids are properly managed. Overall, about half of the mean fluid was administered in the study groups, 5.4 liters versus 10.3 in the baseline group. And overall, this particular hospital had problems maintaining adherence to their septic shock 6-hour bundle. In the baseline period, it constantly stayed at less than 100%. With consistent training over the study period, the study team was able to maintain 100% compliance to septic shock, the bundles, which of course drives the clinical change needed. From a cost perspective, if you're impressed with the clinical achievements from the cost avoidance perspective, looking at the three main attributes here of reducing average length of stay, in this case by 1.58 days, reducing new onset mechanical ventilation by 13.2%, and then reducing acute dialysis therapy newly initiated by 18.8%. There is an overall estimated savings of approximately $12,000 saved per treated patient as a result of protocolizing their volume resuscitation guided by a cardiac output monitor. So you can see how a cardiac output monitor here fits into the overall the strategic imperatives of cost savings by simply using a technology to guide care. If this were to annualize based on this hospital's annual sepsis volume or septic shock volume, which is about roughly 800 patients, that's an annual cost savings of $3.7 million by introducing a technology like a cardiac output monitor into their treatment regimen for sepsis. So that's an example of how this is technology like a cardiac output monitor, like Argos, can be introduced into a treatment regimen to avoid significant costs per treated patient. Now, if we look at the Argos specifically, this is quite interesting. There are obviously other cardiac output monitors on the market, but when we're valuing the total cost of ownership of the Argos versus a competitive monitor, one thing that stands out that's significant to highlight here is that it's the cost or the exponential, the incremental cost of a disposable per treated patient. So we take this for example. Even on the outset, for one treated patient, the total cost for that one treated patient, again, this is just if assuming one Argos monitor was used for this number of patients. It's a single cost compared to a competitor with a monitor plus disposables rises significantly over time as the number of patients, the number of treated patients increases. With Argos, though, there are no disposable costs, so there's a fixed cost that's maintained throughout, whether you're treating one patient or 500 patients, versus a competitor where there are disposable costs, and you clearly see here the disposable costs. It contributes to the rising total cost of ownership to use a similar technology. So that's something, I like the word sustainable here to describe the cost saving strategy when using the Argos compared to a competitor technology.
So Morris, if I could
yes.
add something here.
Absolutely, please.
What I would say on that is that it also gives your staff tremendous flexibility without adding any cost to your bottom line. And again, the reality is that cost is important, and we do have to look at cost so we can continue to maintain what we need in that clinical excellence and high standard and improving standard of care for the patients. So your staff can take that one monitor and you go from one patient to 500 patients, and it's still at the same fixed cost. So without any additional cost to that bottom line for the supply chain or worrying about whether or not you have enough, looking at outdates on disposables that cost, several $100s at times, that you can bring that monitor and round with it. So you can get your information if you're doing your intensivist rounds with it, and or you can do spot checks. So really, with that one monitor at the same cost, you can quickly utilize it, get a lot of information, and move on. Whereas if you are having to bring in another device, it's just not as flexible, and of course the cost savings would go up. So definitely ease of staff use is very important to bring in here.
And to speak to that point as well, I wanted to touch on that too. Just the time savings alone, if you have a disposable setup, you have to be trained prior to using it, how to set it up, how to get your fluid, set up in there, how to shoot those numbers, how to hook everything together. And with this one, it's a 2-minute in-service that is very simple and intuitive to use. So you're not only saving in terms of the disposable, but you're saving in terms of the time you're taking to train your nursing staff to be able to use these other devices that have other parts and pieces you have to know how to use to get accurate and safe data from your patient.
Great and valid points. Absolutely. I wanted to go back a slide, and I wanted to ask actually Jan this as a thought. Jan, you see here the different criteria that we describe as important to when describing a cost avoidance strategy for a hospital and how technology fits into that. I wanted to find out, in your experience as a nurse, ICU nurse manager, do these considered factors of success, do they align with the ones you see here in the study?
They absolutely do. Actually, as an ICU manager, we are generally staffing every 4 hours looking at patients who are ready to leave or can go to a lesser intense level of care because we have other patients waiting to come. So we used to think of length of stay in terms of days, but as an ICU manager, that length of stay that we save even 2 hours means that the patient is more stable. And with this technology, the ability to assure that the patient that's transferring out actually is stable and will not need to return is also important. So it's not just cutting length of stay, but it's also then finding someone that goes out to an intermediate care unit that goes bad, has to come back immediately, or has to have a rapid response or a code. You've avoided all of that by knowing for sure through using this instant cardiac output monitoring. You get a read or two before they leave. If they start to do poorly, you can go out to that unit, and if they still have an arterial line, say if they go to an intermediate care unit, you can catch another cardiac output and give them fluids, and you'll know exactly what to do rather than having a rapid response called and starting the drips and everything all over again and having to go to ICU. So this is a great study, and of course sepsis has been one of my passions as an ICU manager. So I loved the study, but it does apply to what we're talking about today in terms of the Argos. New onset mechanical ventilation sometimes does occur, not so much because the patient has deteriorated from the COVID or whatever issue they've gone to ICU with, but iatrogenic causes of needing to be ventilated for especially elderly patients who are over-resuscitated with fluids can cause them to be put on a ventilator. And then it's very difficult to get that patient off because they don't have the baseline health that allows them to wean quickly. So avoiding the new onset of mechanical ventilation, just because we don't fluid overload, we used to think of mean arterial blood pressure as the gold standard, but it really is not. It's cardiac output. And that gives us the whole story of not only what their blood pressure is, but also what systemic vascular resistance might be, or things that other drugs have caused that change the dynamics. So we can indeed keep them off of a vent if at all possible. And then acute dialysis, if we're keeping the patient's cardiac output where it needs to be, it would be more easily conceived that you do not have renal failure. So if you don't push the patient over into renal failure, you don't need to dialyze. And the tragic part of all of this is not how sick they are in the ICU, but how sick they are when they leave the hospital and need to have a trach or need to have dialysis as an outpatient.
Right. No, thank you for sharing those very salient points. That's absolutely right. On the topic of cost avoidance, I wanted to ask the panel about this particular question. Now, we know that treatment for COVID-19 has disrupted supply chains and increased costs for hospitals. Now, given the staggering demand for certain medical equipment, I wanted to know, what should hospitals be thinking about to ensure the necessary medical equipment is purchased under such a constrained budget? Jan, I like to refer to an example of a tool that you use that to help prioritize some of those capital expenditures under a constrained budget. Would you mind sharing your thoughts on this?
No, I'd be happy to. I've always worked at hospitals that were serving underserved populations, and that pretty much meant our budgets were always limited. So we didn't have the luxury of buying any of the newest things, and sometimes we had to do best with what we had. So my job was really important in that I had to convince people that had the checkbook to buy our piece of equipment versus something else that another unit might need or the cath lab might need. So I put together topics that I would address so that especially non-clinical people could influence for me the prioritization of things that we needed. So for instance, with the Argos, the direct cost is definitely within reason, but the ongoing cost of not having to, or the savings of not having to use disposables, the tubings, the transducers, and everything else that is just for that one patient. And sometimes they aren't just for that one. You know, we open sets and contaminate, drop, and all the rest, or they disappear. So there is a lot of indirect cost with using traditional setup. The indirect cost, though, of staff time and training, and Andrew touched on that, you know, staff time to set this up when they're juggling probably more patients than what they're traditionally used to in the ICU means that they have to stop what they're doing and go in and do a setup and help assist with putting a PA catheter in. Haven't even touched on the cost of a PA catheter that can be avoided. And the cost of that is great, as well as the time that it takes for the entire care team to be there to help insert that at the bedside.
And also the risk to the patient too, just having that extremely invasive line, you know, going in through their IJ, down through the chambers of their heart and up sitting in their pulmonary artery. You know, you don't have any of that with these non-invasive cardiac monitors. And the nice thing about the Argos from Radia is that it's the most accurate and data closest to that traditional SWAN thermodilution physics, shooting your numbers data. So I think that's
Thank you,
important.
Andrew. You're
Yeah.
absolutely right. And as a manager, I'm looking at things like central line, infections and the data that we get held to. And that doesn't mean I don't care about the patient, but as a manager, I have to care about the data a lot, and avoids the risk for that central line infection, which to me was it's just huge.
Mm-hmm.
So thank you. Yes, I'm glad you brought that up. The training, like you said, Andrew, just in a matter of 2 minutes. When I first saw this, I thought, well, what do I do with it first? Well, I turn it on, I put the parameters in, and I connect it. That's it. So it's feasible that I could use that on rounds, as one of you suggested already. What you can do in terms of indirect cost as well is you can avoid the use of certain pressors or have certain medications that are extremely expensive not used or reduced more quickly because you have the accurate data to go by. So sometimes when we're reducing the use of pressors and we have 2 or 3 of them, it's kind of a juggling game, and they're on and they're off and you're not sure, and the blood pressure looks okay, but then you take it down and everything changes, and that's because you don't really have all the data you need. And it's so much more challenging to then go over and shoot a cardiac output that it's not been looked at as being the gold standard. Whereas now it's so easily done that, I could just go over and get a cardiac output and know exactly what I need to change. So patient length of stay, we touched on that a little bit, where we can cut days, but also as an ICU manager, we're talking about hours sometimes of people waiting in the ER and in PACU and other places to get that ICU bed. So the ability to safely and expeditiously get people off of certain drips that we have is extremely important. The patient satisfaction piece of it, obviously, if we don't have to go in and wake them up, that's awesome, because we really believe that patients need to be left to sleep if possible and not go in and do single interventions. This particular monitor can be kept actually outside of the room, which is great for isolation patients. And you don't even have to go in to get a cardiac output, much less put on all the PPE and go in again and go in just to shoot a thermodilution cardiac output. You're just out in the hall and someone coming by says, well, where are we at? And, oh, okay, well, I just look at the monitor and I can tell them what the cardiac output is, and it's pretty impressive. The staff nurse ease of use, anytime we introduce anything into any nursing unit, it's difficult because staff may be nervous or threatened by it or be comfortable with what they have, but especially in ICU, you find there's a lot of new technology overload, and some staff, especially older staff, feel like, oh, I have to learn something new. This is going to be super challenging. And all we need is just a couple of staff to see how this works. And there's almost immediate acceptance of it. And of course, staff nurses worry about whether they will be able to use it and whether they will be competent, but they really foremost look at, what will this do for my patient? And if it's going to make the difference that we know it makes, and it's something that you can add to the mix of things that they do and the data they get, they will be happy to do that because there aren't any real barriers to learning how to use it.
I think it's important to touch on a point here too, to bring it back to being COVID related a little bit. I know personally, and then also a lot of other hospitals around the country have kind of done some nurse staffing shifting, bringing some PACU nurses into the ICU, bringing some post-op nurses into the ICU, just in case there was a surge or a big wave of patients, they would be able to, kind of participate in team and take over some of the roles that the ICU nurse typically would have been doing 100% of. And I know just anecdotally from some of the nurses that I myself was training to do that, and in the last few months because of COVID, one of the things about the Radia Argos that they liked was, a lot of the interventions we're doing in the ICU are very invasive to the patient. If you don't know what you're doing, you can cause great harm. And, that is just not the case with the Argos, and the nurses really like that. You could delegate to them, hey, I need you to go check their cardiac output or index, come tell me what it is, and then I will tell you how to titrate their pressor up or down. And they felt very comfortable with that because, just like you said, setting it up takes 5 data points and a cable being plugged in. It's almost as easy as charging your phone and putting in a couple pieces of information. So if you can do that, you can do this. And so the ease of use and the the staff nurse's view specifically for the untrained ICU nurse, it really lended itself to that staffing changes because of COVID.
I just thank you for your feedback. I hate to cut short such an interesting conversation, but we're approaching our time limit here. So I wanted to just quickly, actually on that sharing what you just did, Andrew. I wanted to, if we can quickly capture your thoughts on a actual case study using the Argos and provide your perspective on this particular case.
So most of my background in my career has been solid organ transplant. It's kind of my bread and butter for nursing. So this study specifically being cited here is 66-year-old female liver transplant patient. And, you know, like Jan and Kathy were alluding to earlier, the kind of gold standard has always been, you know, mean arterial pressure, MAP. How are we perfusing our kidneys and our brain and everything else? And sometimes that is not the only piece of the puzzle that you need to be looking at. Specifically here in this data, if you look at that discordant change vasopressor in quotation marks here, you can actually see that when you start the pressor here, your MAP actually does go up, but your cardiac output actually drops here on the reference SWAN thermodilution numbers, on the RADIA numbers, but on the alternative cardiac output monitor here, the purple line, it's actually showing an increase in your cardiac output, which is erroneous and false data. So, you know, now you're kind of out here in no man's land with incorrect data, you know, basing your interventions on this data that isn't actually actively reflecting and accurately reflecting your patient's state. And RADIA was able to capture that with this monitor, just like your thermodilution numbers would have, but non-invasively.
Great, thank you so much. That's obviously very important, delivering consistently accurate information during times when it matters most. Like during times here, as an example, giving a vasopressor, you want to be able to see that the technology that you have is accurately guiding your treatment decisions. So on the idea of the value of medical technologies and the delay in getting information, we know obviously with the traditional patient monitors, not all information is available, and delay in getting that salient information could hugely impact the clinical outcomes. I want to get your thoughts from the panel on delaying getting accurate information from cardiac output monitors, and how important that is to get not only quick access to the information, but also getting access to accurate information. So let's start, Jan, your thoughts on, if you can comment in context of like vasopressor weaning and getting accurate information.
Exactly. The interesting thing I think we need to be sure and capture is that we don't really need a physician order to do this. We don't need anyone to come and do lines. And so if those vasopressors are being weaned, we can look at this cardiac output and get as many as we want. It doesn't take the time that traditional ones did. And so now we have all the parameters that are listed on this slide within seconds. And we can make clinical decisions, or the other thing is that physicians often will use this clinical information to change to a different pressor that's working more effectively.
Great, thank you. Andrew or Kathy, would you like to add on to that?
Yeah, from the previous slide where we were talking about the vasopressors and what we just spoke, again, I want to kind of point out the concordant change as well, which is representing a fluid bolus. And I mean, how many nurses, you know, go and say, hey, my patient's pressures are soft, we might need to think about lining them and starting a vasoactive drip. And the first response you usually get is, oh, we'll give some fluid. And you know, you want to try and be as most minimally invasive as you can be. I mean, there's a lot of risks with lines and vasopressors and things like that. And I just wanted to point out that in that direction as well, the RADIA monitor was able to more accurately capture the SWAN thermodilution numbers as well compared to an alternative cardiac output monitor. So, you know, not just in the vasopressor realm, but also in the, you know, I'm adding fluid as well realm, it was able to give you more concise and accurate data to targetedly guide your resuscitation of that patient.
Well, Andrew, something we really like especially is that sometimes our patients are in very low cardiac output states, and this monitor is more reliably accurate than the cardiac outputs you traditionally get with thermodilution. So you can have a really, really low state of maybe 1.8 and know that that's really and truly the number.
And the only thing I'd add here is that we have across the country many highly skilled critical care nurses, physicians, and other healthcare providers that truly understand hemodynamics. And this gives them a tool that they are able to quickly assimilate what they already know. And it honestly, you got to have fun at work. This is something fun, brings in, not a barrier. You never want to give your staff a barrier. You want to give them something that's value added, definitely value added. And when there is that continuum where you're utilizing a resource pool that you might not always have, the education, the training, and being to have and able to have kind of a captain of the ship that can look at this and then make changes based on that patient need that the Radia Argos monitor is giving you.
Yeah, absolutely. Great. Thank you very much for your perspective on that. I wanted to bring it home by just rediscussing some of the key takeaways here. Given the idea of what we were discussing today in the context of the unprecedented financial burdens that are on the healthcare systems as a result of COVID, there is an obvious strategic imperative to balance quality and quantity of care. And a shift in supply chain strategy has made it a little more complex, made it more difficult to create those strategies because, again, these are new times for everyone. But the Argos has, as you all have accurately pointed out, has been the solution that helps drive some of that change by delivering consistently accurate data that decreases ICU length of stay by seamlessly fitting into the clinical workflow to minimize disruption, especially during a time when many hospital staff is extending the use of PPE or forced to stay outside of patient isolation rooms. The Argos is being able to meet that need through just a simple single cable connection. And of course, the no per patient costs that lowers the total cost of ownership compared to other advanced hemodynamic monitors. I think all of those things contribute to an overall total cost savings that is a significant big piece of the puzzle that will help drive effective change for the hospitals. Just before I go into and transition into our audience Q&A, I wanted to open up to the panel to share your thoughts on a key takeaway for you that you would like to leave with the audience.
If you guys don't mind, I'll just go ahead and start. And one of the things you think of when you've got those competing priorities, and Jan with her value analysis, tremendous breakdown of what they need, and listening to Andrew talk about the ease of use with patients, the real-time experience. So you're really thinking about capital. Is it something that's going to be nice to have, or is it something we really need? This is something that I would say is needed for the bedside, prioritized into the care delivery model for protocols because it's so flexible. The resource allocation to different units is really seamless, and education, it is ease of use and accurate, precise, immediate information that all of your bedside clinicians can use. So when you're weighing that, I've got this limited budget, so what am I going to do with it? Nice and need, this goes on the need side.
And definitely, for sure, to kind of tie into that, like the bottom line is no matter what type of siloed ICU you're in, whether you're a mixed all the way down to like neonatal or any type of critical care continuum ICU, there's going to be patients that you need to have real-time cardiac output and indexes on. And as far as my anecdotal experience, my clinical experience, the Radia Argos by and far, goes above any of the other devices I've worked with in my career in terms of all those parameters you just mentioned. So if you're gonna have to get one, why not get the cheapest, the most accurate, and the one that your staff's gonna like to use the most,
My perspective is if I can give the staff a tool that they feel like is helping them do their job, they will be more satisfied. And many times satisfied staff is worth, to me anyway, giving them what they need to accomplish the job. Once they see and use a monitor like this on an acutely ill patient, they will be the biggest champions of it.
Great points, great points. And thank you very much for sharing your perspective. I'd like to now open it up to some audience questions. And the first question here asks, and this is directed at anyone on the panel, how do you educate staff to look at trends and not isolated data points? For example, does position affect data validity? Who'd like to take a first crack at that? Andrew, you recently trained staff.
Right.
So how do you, when you're training staff on the Argos, how do you train to look at trends and not isolated just individual data points?
So one thing for sure that's important to any ICU nurse that's learning how to be an ICU nurse in critical care is you never just look at one thing. If you go to an intensivist and you say, hey, patient is doing XYZ, and you give them one piece of information, very rarely are you going to get the change you want or anything at all to try and target that problem. So what you need to be more attuned to is, hey, when I first started my shift, my patient was on, this dose of Levophed, and now we've tripled that in the last 2 hours, and the last hour was 70% of that tripling. You know what I mean? Like, you see this logarithmic curve where things are starting to go in a direction more rapidly than what you want, and that's where we need to target our interventions. And unfortunately or fortunately, cardiac output and index traditionally wasn't the most easily available data to get with thermodilution and swan lines. And now it's very easy to be able to trend that data with a device such as the Argos. One of the features specifically that would really speak to this is, let's say you do have this patient that's kind of heading south from a blood pressure perfusion perspective, and you decide to give a 500 bolus of normal saline, right? You can actually, hit a little icon on there, intervention, type what you did, 500 bolus NS, and then it resets this little percentage data point under your actual cardiac output number. And then once that bolus is infused, you end it, and it'll give you the percentage change. So really what that's doing is giving you a piece of information to be able to go then to your provider and say, hey, I gave that bolus, their cardiac output improved, 22% just in the time I gave that. Maybe they could go a little bit more, or hey, I gave that bolus and their output actually decreased by this percent. Maybe we do need to start a vasoactive medication.
Great answer. Kathy or Jan, your additional thoughts on that?
Well, I was thinking about that, Andrew. I love what you had to say. As a nurse, though, as a bedside nurse, I would want to have a lot more trending, because blood pressure is so labile according to ventilation issues and movement and noise and everything else in the room. Whereas the cardiac output is, you want to trend it, but you don't really need to trend it as long to get the information that you need to make a decision.
And the other thing I would add, I think part of the question was position, et cetera. And if you have got an accurate A line, you've got your arterial line 0 to your monitor, you've got accurate information going into the Argos. So the positioning it's really just the accuracy of your A line.
Absolutely. Great, thank you for that answer. A question I was curious about, this is directed at you first, Kathy, discussing the idea of, we talk about supply chain disruption, and Argo certainly does not have any per patient cost because there's no disposables required to operate the system. I'm curious on your thoughts on that impact on the monthly burden of on the supply chain, and in your experience as an administrator, what is the monthly burden for technologies that require having a disposable, and what is the true advantages of not having, not needing a disposable?
Well, it's overwhelming. I mean, you can look at then diverting that money into other areas, because of course, in the best of times with the budget, you're looking at your yearly budget. Once that's out, you're already looking at your next year's budget, and you're looking at, what do I need? And then obviously every place has a 5-year, 10-year strategic budget. And then now everything's been blown up and everything will be looked at again. But to not have, to say you're going to spend a couple $100,000 for one unit for disposables, and then over X period of time, whether that's a year or whatever it is, I don't remember the exact number from your slide, then you can take that and, bucket it into another area. Or, so any cost avoidance really is a cost savings, and sometimes that's difficult to understand. But when you're avoiding costs here, then potentially you can still, if you have the money available, put it somewhere else. So anything that you can bring in that you just need to do your software upgrades, you need to do the maintenance with Biomed, that you really can plug and play and not have to spend that extra money on the supply chain. It helps, Jan as a unit manager would not be looking at, oh my goodness, I've gone over $80,000 in disposables because I had such a high volume of COVID-19 patients or whatever it is. So I guess I'm not sure if that answers your questions, but just my first thoughts on that.
No, absolutely. That was a great answer. Thank you. That's exactly what addresses the question asked. Jan, I wanted to ask you about something you brought up with the value analysis chart that stood out to me. You had talked about the indirect costs, and oftentimes this is kind of overlooked, indirect costs, because it doesn't have thinking about the capital purchase, or in some cases, disposable purchase. But the indirect costs, amid a time when there is a shift in provider to patient ratios. So you have less staff taking care of more patients. I wanted to get your quick thoughts on the value of a technology that can help, that fits into the workflow while you have let's say an ICU nurse taking care of 4 patients, where before they were used to having a 1-to-1 ratio.
There's definitely cost savings, but I think in the bigger picture, the cost savings that you would have, you could divert that money from the disposables as well as from the staffing to purchasing equipment that makes the job able to be done, as Andrew said, by people from other areas with minimal training. And that nurse, the ICU nurse taking 4 patients, can feel more comfortable managing those patients with the help of people that potentially cannot take care of ICU patients on their own.
Right. That's a great point. Any additional thoughts on that, on resource allocation, indirect costs, staffing costs, anything like that? Okay. This is not a question, but a comment. The comment reads, "This sounds like a good system, but my hospital is currently under contract with another cardiac output monitor that requires disposables. I think I'll have to wait until the next contract renewal comes up." I'm assuming comes up to before making a switch to the ARCO system that does not require disposables. Great, thank you. Not really a question, but thank you for the comment.
And remember, we can always, I'm sure you could contact them and always do some kind of a trial or evaluation or something as well.
Yeah, so arm yourself with information. I think the one thing going through this and listening to our other panelists and having information on the Argos Redia is that really it can bring a very good synergy between administration, that frontline management staff, for that, again, highest quality of care, improving quality of care. There's no one on this webinar that doesn't want to be providing the best care in the country for the patient that's in front of them in that bed. So again, I think this brings a lot of synergy and a lot of good reasons to take a look and further explore. So thank you for your time, and Morris and Redia, thank you for inviting me to this webinar.
I had one extra comment, and this was about the contract subject that you brought up, Morris. If you have a contract with somebody and they supply you with your monitors and disposables and all the rest of it, there are still patients that you need to use those with, potentially like severe cardiac patients where you might need a pulmonary artery wedge or something else. So you're not really excluding the product from that company. This is more of an add-on. It's something you would use when you don't want to have that pulmonary artery catheter.
That's a great point. Great point. Yeah, absolutely. Well, I have time for one quick, this is a yes/no question, and it seems like it's directed for me. Seeing that quality improvement study, can my hospital set up a quality study with Argos, and will you share a protocol to assist in setting the study up? The answer is an emphatic yes, absolutely. Please feel free to reach out to me, and or just send your email to info@radiamedical.com, and it'll get directed to the right person. But we're happy to help with that. So, panelists, audience, thank you all for your time. Panelists, thank you again so much for your expertise, your perspective. It was extremely valuable as in our discussion with costs and innovative technologies to help abate some of those costs. I wish you all well, and hopefully we'll see you soon on a future webinar.
All right. Thank you, Mark.
Bye, everyone.
Bye.